But if you go from the corner of the eye to the top of the tragus in women, and the corner of the mouth, and draw this right down like this, and this all comes off real easy, so don't think you have to wear it for the next 3 or 4 days. So corner of the mouth, top of the tragus, and draw a line like this, and around like this a little bit. And then even in your most visual patients, they can look in the mirror and they can see what side. I already determined this before I almost got you over here. Determine what side of your face is fullest, because each side's not a twin, it's a sister.
You said before that the right is usually fuller.
Usually. Look and see if what yours is.
I think my left is fuller.
Look and see what yours is. The right side. So when you draw, usually patients can see it instantly, so you can kind of show them that's this side's a little bit fuller, and you're not trying to create issues that the patient doesn't have, but this side's definitely a little bit fuller. And her apex of her cheek is really beautiful, but she has a little submalar part of the cheek that could be lifted a little bit. Now, if we measure her, just quickly here.
And so this forehead is high too.
Yeah, and that's not good or bad. That's just you. But there's something you can do with that actually. So you wear your hair up or down.
I wear it like this or in a ponytail, just because I'm low maintenance.
So usually I have patients watch, but it's hard to do that. To open your eyes here. So we won't stick you. It looks like I'm going to stick you. But to go right at that distance between the eyes, between the inner canthus, that is number 1. That's 1. So I usually will just turn this knob down a little bit, so make sure it's tight. So that distance between the eyes stays the same from 19 to 90 kind of thing. Now she's got a beautiful peak of her brow, and where that peak of the brow should be is from the corner of the eye to here. So her peak of her brow is right on, and that distance between the brows should be the same distance between the eyes, and so it's just her eye is really good. She knows where to shape her brow. It's just her brain tells her that. So the distance between the ale of the nose is here, and the maximum volume of her lower lip is here. So for my eye, her lower lip's too big. It's too full. So she's got her lower lip is full all the way across, and it's just the eye doesn't particularly like that. It's okay, but it's just a little bit off. So you're trying to do like we used to inject. We used to inject the whole lip, and it doesn't quite match the persona of your face. So the other side of this is phi, which is the length of her brow, which is pretty well right on here. And then that should be also the length of her nose. Is her nose short or long or right on? No, it's short. And that's not necessarily bad, but you can make it longer by where you inject filler. So the length of her nose is quite a bit off here. It's quite long. See, Arthur? Length of her nose. It's quite off here. It's a little short. But that's not bad or good necessarily, but it doesn't balance the face. So you can actually change that a little tiny bit and improve it. So the height of her forehead is the length of her brow, and she already knows intuitively that her brow's a little high. So you can teach yourself to change. It's hard to change hairstyle because it's just difficult because of change. So the apex of her cheek should be from the corner of her eye to here, and her apex on a 45-degree angle, and her apex is just right on. The width of her lips should be here, and that chin should be here, which is right on. And then that, if we go back and measure the distance between the philtral columns, we'll measure, and you want to measure, where do you measure, Arthur? Right on the column or medial? Arthur? Sorry? Where do you measure your distance for the philtral columns? I measure just to the outside a little tiny bit.
Yeah, so the philtral columns are normally not at the level of the peak of the Cupid's bow. We call it the Cupid's peak because the bow is actually the entire lip, but just medial to it. It's just inside the peak. You take a look at Angelina's lips, it's just inside the peak. As we get older, it splays and gets wider. So you really have to make sure that if you're going to create a Cupid's bow, that you create it medial, just medial to the actual Cupid's peak, like Kent is marking out right now. She has beautiful Cupids.
That's a really nice Cupid's bow here.
No.
And her lip is just a little bit out of balance, but I mean, most things about her is absolutely stunning. It's fantastic. So, Arthur, if I was going to do anything, I would do the submalar part of her cheeks, and I would do a little bit. Her chin has a tendency to be, if you looked at her in photograph, you wouldn't actually pick this up, but her chin has the tendency, you want the chin in women to be beautiful, smooth, soft curves, feminine, but it's a little square here. So I would lift, and the chin reflation is all about the lateral commissure, marionette zone, pre-gel sulcus, and the mentalis. It's about all four of those zones. So she thinks she's a little jolly, but that's actually, this is a symptom. The cause is in front, and a little bit of her chin is just a little bit off there for me. That's what I would do, is submalar part and her chin. But we let them tell us what they're going to do.
Right.
Okay? So.
Make my nose longer.
Of course, we're going to make your nose longer.
Yeah, I make her nose a little longer too.
You'll get bruises on it from your knees when we're finished.
I do not care.
She's fairly, I mean, to me, she's fairly Miss Perfect.
Yeah, so the question is, when a patient like this comes in, a patient like Betsy comes in, the question is, to me, right off the bat, is it an easy case or is it a hard case? To me, this is a hard case. She's a 9.5 out of 10. Sorry to take off the half, sweetheart. 9.5 out of 10. You have a half to make her better, 9.5 to downgrade her beauty. You don't want to downgrade her beauty by putting stuff in that's going to depreciate her value rather than appreciate it, right? Okay, so these are the cases that I actually do reach for the calipers because I need their guidance to see how small amounts of product are going to make a significant difference on her face, just like Kent was going through. So if you're holding a syringe in your hand, there's only one of three things that you can treat. If you look at the areas in thirds, you can treat the line of that third, the lines, in her case the transverse forehead lines or the glabellar lines. You can treat the volume of that third or the contour, in which case it's the contour of her forehead and her temple. Or you can treat the feature of that third, and the feature of her upper third, as Kent went through so beautifully, is her eyebrow. For the middle third of the face, again, if you be systematic about it, lines are going to be the crow's feet, could be the upper nasolabial region as well, could be mid-cheek lines, bunny lines, right? If you think lines, volume, feature, you won't miss anything. Volume, it's going to be, again, contouring or volume or contouring of the cheeks, and the feature of the middle third is the nose. People forget to look at that. Think lines, volume, feature of the lower face. The feature of the lower face are the lips. Okay?
One thing that is that you always have to think, too, of the advantages, the disadvantages, and the disadvantages of the advantages.
Oh, great.
So with her, the disadvantage of her being so good-looking is that it's hard to make her much better. When someone has got poor genetics, the disadvantage is it's hard to make them look much better. The advantage is that you've got a lot of work to do, but you have to weigh the disadvantages and the advantages.
So, let's take a look at the upper third again. So what I want you to do is to try to frown, clench down. So she's got some toxin effect, but it's just about wearing off. When was it done?
I can't remember. I just do low levels every so often because I don't like to be frozen.
You're a small repeat offender, as we call them, right? Okay. Raise your eyebrows again. Beautiful. So you have some activity, which I'd like to see, and you have some static lines over here. Great. And a big smile. Okay, so she has a lower fan pattern. If it was Michael Caine who was assessing her over here, you talk about the lower fan pattern of the creases overlying the lower orbicularis, but the upper orbicularis seems to be spared quite a bit. Close your eyes and close them tightly, please. Ah, that's what I want to see. This is what tells me whether toxin will go ahead and boost up the corner of a brow. You have some patients you can relax. You have some patients that when you put toxin in over here and you expect the brow to elevate, it doesn't. And that's because if you ask them to crunch like this, go ahead. Look how much movement she has there. She has about 4 or 5 millimeters. When you ask them to crunch, it doesn't move. There's not a whole bunch of orbicularis contribution into depressing that eyebrow. So on her, putting in a little bit of toxin over here is really going to boost up the corner of that eyebrow if you so desire.
Okay.
So you take this distance over here and you can see that her eyebrow height actually over here is a bit low. And you can tell it also because it's sitting a little bit below the orbital rim.
Yeah.
So ideally, I would like her to come up just a tad.
I would like that too.
Yeah, so you have to go after the depressor supercilii over here with toxin if we were doing that. Close your eyes tightly. It's still active. Do you see that? Okay, you can see these lines over here. So that my injection, I won't do it right now, but my injection for toxin on her, where normally you're going after the belly of the corrugator over here, my injection would be down here. And the idea being is that I want to elevate that part of the brow as well. Okay? Got it?
She's also, while you're right there, she's got a post-blepharoplasty bowstring.
Yes,
What is that?
this little web that he's talking about over here, that we would treat with laser. See that little web?
Yep.
Yeah, that's not a big deal. We're going to tear you apart here, girl.
Please.
Okay. So again, as I was explaining to some of my colleagues on the break, is the fact that injections into the glabella of toxin, whether it's Xeomin, Dysport, or Botox, are done not just to eradicate lines, but to create a beautiful glabella. You saw the pictures that Ken showed you of all the different glabellas and different unibrows and things. Having a unibrow and having a lineless brow over there isn't a beautiful thing. So we would want to elevate her a little bit over here. We want a 10 to 20 degree upturn. We want this to be this distance over here, which is the peak of it, to be at phi.
It's pretty right on.
Right. And we want the tail of the brow in a female to be at the level of the medial brow or slightly higher. So I really think this brow's doing pretty good. This brow here looks too low to me.
Yeah,
I think so
it is.
too.
Yeah, and so she would really benefit from having this tail kicked up a little bit. And I would use toxin to do that. And I can also perhaps,
Steve,
the
on your
fact
right
that she
side.
had, the
Keep
fact
on
that
your
she
right
had a
side,
temporal
right side.
lift, you see where that incision is? It's over here. You know, she's pretty flat over here a little bit, but I want to see if we can actually get an effect on the tail of the brow by putting in a little bit of product here. So do you mind if I do your temples?
But you do whatever you want.
Yeah, I think she
Okay.
sleeps on her right side.
If we turn the face on the lateral position,
Yeah.
okay?
But I try to make
I can't see it. This monitor is really set up the wrong way.
I trained myself.
Okay, turn your safe maybe all the way towards me. That would be easier. We see her on a profile. This is the typical thing. She's 41. This is the typical thing that we see is the increased convexity over here and this hollowing or flattening over here. If I was to lay the caliper over the top, you're going to see that there's a gap over here. It's kind of obvious. And that gap runs from here to here to here to here. Okay? We mark out her temporal fusion line. It's right here. I'm sorry. Relax. Here we go. It's right there. Her temporal fusion line is here. And her temporal fusion line is here. She's a little asymmetric on her volume loss. She has a little bit more on this side. Maybe a little bit less there. I'm going to plan injections on her forehead because she said I can do whatever I like. I'm going to plan injections on her forehead, and I'm going to use a needle technique. Maybe on the next patient we'll use, or the next volunteer will use a cannula technique. And I'm going to space my injections about 1 centimeter apart, which means that I usually end up with about 6 puncture sites. 1, 2, 3, 4, 5, 6. Okay? Am I safe to inject into that area? Yes or no? Superficial or deep?
Did he make some minis with
Oh, you lucky. They were paying attention.
They were.
What kind of product do I want to use? A product that lifts or a product that spreads? Good for you. So what I've done is I've gone ahead, and we're going to use all the company's products today if we get an opportunity to, because I can show you that there are no bad products. It's just understanding the personalities of them. I have Restylane Silk over here, which is a very spreadable product. It's a very thin product. It works very well. I've bastardized it a little bit, if you'll excuse the expression. You can take a look over here, and you can see that I have a little bit of bubbles in it because I've made champagne resty. Okay?
So
I'm going
when
to...
you're doing the assessment, you could tell just because, I'm sorry, I'm looking.
Have a cleanser, please.
This side, my left side is, this temporal fusion line is here. So just as far as thinking of the assessment and knowing where to inject the product,
Right.
how,
I'm looking from the lateral view. You can't see it.
Okay.
I'm looking at the lateral view and seeing that there's a contour deficiency over here that stops here. And when I look at it from the lateral view, I see that it continues on over here. So there's a little asymmetry. I'm not planning an asymmetric result on you. You just seem to be a little fuller on this side, so that we're going to do that. If we see afterwards, when we erase it, that you're missing a little product here, then we'll do it over here. So I can inject here. I have to be down on bone, here down on bone, here down on bone, here down on bone, here down on bone. And I'm probably safe to inject here. What am I worried about over here? The nerve. I'm causing her some pain. But I think her nerve is going to be sitting a little closer to the fusion line. But we'll inject to the inside of that and push it over. I'm going to use, unfortunately, we don't have chlorhexidine. What do we have? We have maybe that cleanser that you gave me before. Give me one of those little packs over there, please. I don't like to use alcohol only because of the fact that, A, it reminds me of a doctor's office, and I used to go for injections for allergies when I was a kid, and I'd start crying every time I smelt the office. So that's number one. And number two is it makes the patient's face look a little red on demonstration, you know? They get a little red. So I like using chlorhexidine better than that. But I'll use this pad over here, and I'm going to clean, because I'm going to target this. I need a dry sponge, and I need my assistant on the other side. Well, he's over here. Let me have some dry sponges. I'm always keeping sponges here.
That's separate. It's going to be a little
During the summer, I hook them under the bra. If you ever come to Montreal and see people walking around with epaulettes like this, they're coming from my office. I forget to take off the sponges. You'll see my nurse chasing them down the street. So I have my product. It's a 50-50 blend. I'm doing that because I want the product to spread beautifully and I want it to get the water that it's looking for. I'm going to turn her face slightly towards me. I'm going to come in. I want to make sure that I'm not in shadows over here. Oh, I see where the camera is. Let me do a little bit this way. That you can see a little better? Still have it. Are we in as tight as we can go? Where's my camera, guys? Oh, beautiful. Okay, that's it. Oh, I love it. Perfect. We'll concentrate from here to here. Great. I'm coming in over here, you guys can see. Perfect. Sorry about the shadowing. I'll come in maybe at a little bit of an angle, but I usually go vertical. You're going to feel a small little stick, Betsy.
She's injects herself. This will be a party.
Yeah, so this is a piece of cake. I'm in on the skin right now. I gave her a little pinch as I did that. I'm starting the flow of product. I might have gone through a vessel. I don't know, but I know that I'm on bone and I'm safe. I'm starting the flow of product. You're going to see the skin bump up just a little bit. I've already injected 0.05, not a whole bunch. I'm ready with my pad in case I hit something, which I didn't. Lucky girl. And I just do this. And that is a whole forehead injection. Finished. And typically, I will go across the forehead. You can do this with your little circles. It's a great thing to do as long as you clean the center of the circle. You can do this with your circles because if you're in a busy practice and Kent is injecting and all of a sudden his nurse sticks her head in the room and says, you know, there's a patient who wants to know this, that, and he's distracted. He knows that he's already done this area because the circle's gone. So you have an inventory of what you've been doing as you're going along. Now, I just want you to look already to see what's happening to the line in that area. The lines now have stopped. They've come along over here, and they've stopped. I started off with 0.18. I have 0.16. Why is that? You think it's the lidocaine effect? Can you raise your eyes, please? She's moving perfectly well, and you can see when she raises them, go ahead, that she's practically got no lines over here. It's a weird thing that happens. I'm working on it, and I'm telling you, I think that the second that you start to give muscles a little bit of support, they start to act like they were young again. They say, wow, that's a contour I had when I was younger, and they do that. So we're going to move to the next one. I'm right over where the supraorbital or supratrochlear is. If there's a vessel that I can see, I'll try to avoid it, but I can't. I want to make sure my hands are not in the way. And I'm going to give a small injection over here. There she goes. I'm on bone. I have to feel the bone. Giving a small amount. Look at the bump that's forming. I pull it out, and then I do a little bit of pressure like that.
Now, there's three main reasons we use these little minis. One is the rheology. It's very smooth, even with Voluma or Perlane. Number two is it's like a fine paintbrush. Number three is we use only like 0.2 amounts because if you use more than that, it's a little cumbersome, and because these are meant for one injection and they get dull.
Correct. And you can just discard it and you have zero loss of product because it's a swathed needle. It doesn't have a hub on it. These things will get dull usually after about 4 or 5 injections. Yep. When I'm using a needle that is hubbed onto the syringe, I have to change the needle after 3 or 4 injections because it gets dull, and I lose the product that's inside the hub. And I'm a miser when it comes to product because I love to save product for the next. Out of 10, if 0 is no pain, no, it can't be 0, sweetie. If 0, it was 0. That would be called painless, but I don't tell patients it's painless. I say it's minimal discomfort because I usually get a 1 or a 2 or something out of that.
That flick thing is good.
Okay, so why do I do the flick thing, guys?
Distraction.
It's distraction. It's Melzak's theory, right? It's Melzak's theory of gate theory, that the brain can only handle, that homunculus, which is the monkey in the brain, can only handle one sensation at a time. It's going to handle the sensation that gets there first. Lucky for us, pain fibers are unmyelinated delta fibers. They travel slower than movement fibers, which are alpha fibers that are myelinated. And so the movement gets there. The brain is analyzing the movement for that part of the face. And when the pain gets in behind it, the brain says, sorry, I'm busy, I don't want to pay attention to you. So you limit the amount of pain by doing that little flick. Very commonly what I do is I will distend the skin like this and then flick the skin back into the needle. So it's skin into needle rather than needle into skin. And I think in the old days...
We used to twist their toe.
Yeah. In the old days of Harry Carey, I think they used to fall on their swords and not jab themselves because it was less painful to commit suicide that way. That's probably the story. If you hit a small vessel, artery, or vein and it starts to bleed, you don't panic. What's the treatment? Pressure, not ice. You put ice on a patient, it hurts. They'll hover over it and they'll bleed underneath it. Ice is for after the bruise is already there or after there's swelling and you want to take it down. I started with 0.18, we said. I'm down to I've used 0.1 cc's of product so far. And that product is a 50-50 blend. And you're going to say to me, yeah, but you know something? The lidocaine is going to, be reabsorbed and there's going to be nothing left. You're going to lose your effect. Really? I could take this product and I can go ahead and put it onto the syringe. Look at the control that you have, that I can hang a drop off the edge of the syringe. Do you see that? You can't do that with a bigger needle. And I'm also using, as you can see from my injection technique, where am I here? There you are. I'm using the base of my thumb. So that brings me to a story, because there's always stories in the big city. Can I have the cleanser, please? I'm a nutcase about cleaning all the time. And if you wanted to do this, I want to show you now with half the forehead done that you can see the contour of the forehead on this side is turning out to be nice and smooth. And the contour on this side is asking for it. There's whispering. There's got to be questions. Go ahead. Don't be afraid. No such thing as a stupid question. There's lots of stupid answers, and I got them all, so don't worry about that. I'm using Restylane Silk. Fine lines for people from Canada. Touch for people from Europe.
And, yeah.
I'm trying to keep myself, because of the lighting here, why am I getting a shadow? Where's that shadow coming from?
I don't know where it's coming from. It's annoying.
It is, but where's it coming from? It's not coming from here. It's coming from those lights over there, I think. And I'm right-handed, but you know what I'll do? I'm going to switch. This is just Resty Silk. Think about what we're talking about. Good question. Oh, I want to talk about this area here too, that somebody asked me a question. Think about it. What are you targeting here? What's the depth that you're targeting with your injection? It's on the bone periosteum. Is the muscle there? It doesn't make sense to blend. When I'm targeting here and I'm underneath the dermis, I'm targeting the superficial fibers of orbicularis, what I want with my toxin. Would you blend? Yes. How about the lip?
Yeah.
How about platysma? So people who originally described blending the product in for doing the lines over here, it didn't make sense because you're putting the toxin into the dermis and you want it to go into the belly of the muscle. There's two different locations. I want to talk about this because somebody brought up the point and they were very right on. I told you that you got to be careful with the needle over here, but I didn't say that people will say, well, what happens if I treat it with toxin and she still has a couple of creases over here and she wants to treat the creases? You want to fill it. Why can't I use the needle to fill it? You can. Going into the dermis over here is fine. Dermis on the face is fine anywhere. The risk that you run is bruising. On the nose and in the glabellar area, because of end arteries, you run the risk of causing a small ulceration if you put too much product and get some pressure on it. You have to make sure that you're inside the dermis when you're using a needle over those creases, because I told you right under that crease is supratrochlear artery. The depth from the skin down to the bone here is 2.4 millimeters on average. The average size of a supratrochlear artery is 1.8 millimeters. That leaves you 0.6 millimeters of play. You're not that good. Nobody is. You can't find 0.6 millimeters with the tip of a needle. So you must make sure that you're intradermal if you're going after a crease. And the way to know that is you can certainly see the tip of your needle and cause a blue streak over here, but that would be stupid, is to feel the pressure on the plunger. If there's resistance on the plunger, you're intradermal. If you start injecting and you lose the pressure, it means you've ducked down subdermal and the artery might be right there as you stop injecting. Does that make sense, guys?
Yeah. Yeah.
Okay, great. I'm going to continue across over here. And they can get, see if you guys can see it a little bit better from this side. I think you can, huh? You can get small stick right down on bone. My needle's starting to get dull now. I can hear it working its way through the skin, but she's an amazing patient. Okay, I'll do it this way then. I'll use my 2 fingers like that. How are we doing, Betsy?
I'm great, thank you.
You're great. Good. I'm doing pretty good too. And you can get some gentle undulations of the skin over here.
Want some gel, Arthur?
Sure.
Gel.
I need to do one more injection here, but I'm going to take off this over here because I want to show you something. Remember, I have added in lidocaine over here as my I won't use the word dilutant, as my blend. Raise your eyebrows. Look how few the lines are now over here. She still has movement of her eyebrows, okay? And I've used a total of 0.18 of product, which is 0.09 of product blended. She can use maybe one last little injection there. We'll get to it in a minute. Sure. We take a little bit of ultrasound gel, or I use a little arnica gel. Ultrasound gel is great because you can, it's nice and cool. We do this what? For proprioception.
Yeah.
Your fingers feel what your eyes can't see. We're not doing this, you know, for any other reason than just to make sure that the contour is nice and smooth. If we feel a little irregularity, you can tell patients that they will have a little bit of irregularity for maybe a day or so, but when the product heats up to body temperature, it'll be nice and smooth. And you know what? That's going to stay for probably close to 2 years. And you're telling me it's crazy. But I'm telling you, you're going to see that she's going to say that her demand for toxin in that area is going to be much less. And you can see, I wish you can see from my point of view, but you can see over here, you can see that she still has lines over here that are static, but she has no static lines over here at all. And if you treat her upper forehead now with a little bit of toxin, she's going to have just a stunning forehead.
Now, if you got patients, particularly guys, that you can got creases that you can drive a Jeep through them,
That's fine.
then
Great.
then
Oh, great. You found
what I
correction.
do is use a cannula to break them up, and as you break them up, then you can inject. I'm
Is
not
this my
sure,
resting?
Arthur, do you use on the heavier ones with those deep creases, so you got to drive the Hummer through them? You can
Sure.
use a cannula, or do you still use your needles?
I find I can't get a cannula into dermis, so if I'm going subdermal, I'll use it.
Yeah.
But otherwise, I can't. I have to use a needle. So she's really lucky. We didn't bruise her. We didn't do anything. But that's the whole idea. It's a very calm thing. She can go out now, meet her friends. She can move her eyebrows. She looks great. And it's going to be nice and smooth. I'm going to move on to the temple unless there's a question about this. Fire.
Did you use any epinephrine at all?
Yes, very, very mild. Yeah, so what I did was, to show you how I do this, and I apologize to the companies because they get upset at me, but that's what they're supposed to do, is get upset at me. And it's not only my wife that should get upset at me, it should be other people too. Where's the other 3cc syringe that I had with the... Oh, here it is. Luer lock to Luer lock female adapter. Nobody knew about the company Baxa until I discovered that they had these things, and now all of a sudden, like I should have invested in them. Just for this, for these little Luer lock to Luer lock adapters. They come in a box of about 100 or something, and they're all individually wrapped and sterile. And what I would do, to be honest with you, is that I would take a marker, and I would write on the side of it, RS, which stands for, and I'll use it all day long. For Resty Silk. I'll keep it sterile by just putting it down on a gauze and not touching the areas that I connect to. And I'll know that this is my Resty Silk marker, and I'll do it from room to room if I want to blend. Okay? So what I did was I drew up a cc of product over here into this one. 1 cc, right? And on the other one, I drew up 3/4 of a cc of lidocaine without epi and 1/4 with epi. So I had 1 cc in one syringe, 1 cc in the other syringe. I connected them up, and I mashed them back and forth about 20 times because I'm obsessive. I like to count stairs when I'm walking upstairs. I'm an idiot. So I did it back and forth, and then I put it all into one syringe. You can see the syringe is a little bit cloudy. That's the light. That's the champagne effect. I attached a 25 gauge needle onto it, and I backloaded my syringe. I take off the plunger, the cover for the plunger. I leave this on. Out comes the plunger. I keep it sterile. My nurse does this for me. You see this? I put this inside from back, so everything is still sterile. I start the flow of the product. This is Poiseuille's law in action. It's not going to flow forward because the needle side is smaller than the open side, so the product is going to flow backwards. You see it?
Don't use an 1.5-inch needle because you want the product proximal, and then you can push the air out distal.
Okay.
And you can just push the air out now.
And now I put my plunger back in and watch the product. There goes the air. And I have 0.2 cc's, 0.22 cc's of product. This is sterile. This is sterile. You got it? So that's the kind of technique that I use to switch these things. And it's amazing, like Ken said, it's amazing that the dexterity and control you have of using these small little syringes. Okay. Yeah. Oh, you're so on top of me. Can't breathe. Can't breathe. Thanks for the question. Okay. So let's say I have this over here like this. And I decided that, let's see, I'm going to be doing, this would be a great product to use to do the crow's foot area with a 30 gauge cannula. I pull back and give myself a little room. I draw up how much would I normally use for a crow's foot? 10 of Xeomin or Botox, 25 of Dysport. Is that fair? I take it and I just inject it into the top here. It's sitting over there. I connect it back up and okay? That's how I do it. Does it spread out evenly? I can't tell you. I'm telling you, this is witchcraft. It's heresy. When I mentioned this, I was mentioning it just in little groups because I was nervous about it, but people started coming back. I've been doing upper lips like that, doing it this way for upper lips. I've been doing that now for about 19 months, 20 months. Okay? I do it, I load it up just like Ken showed you with his 30 gauge, and I do the subcision, and I'm putting in filler and product both in the same, filler and toxin both in the same location. I want the superficial fibers of orbicularis for the pursing. I don't want the deep fibers, but that's more for competence, oral competence. So I'm putting the toxin where I want it to go. I'm softening the muscle, and I'm putting a coating, a subdermal sheeting, as we call it, between the dermis and the muscle. The reason that we get all these little creases is because the dermis is stuck down to the muscle. It's being accordioned. What I've done now, and Kent has shown you his technique, is we've released all those little septi, and I've put a spacer in between the dermis and the muscle. Okay, I put a spacer in between, and I put something in that's going to keep the muscle from contracting too hard. What do you think happens over the next 3, 4, 5 weeks? As things start to heal, the collagen comes in and it tries to grab the dermis. Guess what? It can't because my spacer's in the way. And so it heals with a smooth contour texture. So the patient looks better 3, 4, 5 weeks later. And when I go back to inject these lips that I've done, now it's 19 months ago, I got to tell you that the first lip I injected again was after 13, 14 months. When do you get that type of longevity out of doing anything for lips? You don't. The combination works amazing. But that's my heresy. Guys, I'm not telling you to go out and try doing this. If you want to experiment a little bit, you can put a little bit of toxin in. You can play around with it a little bit. What I was doing originally was just coating the lip and then going in afterwards with my needle to put in the toxin. I was putting it into my filler. So, how much would you use? Right, so I use 4 units, so I put 2 units on one side, 2 units on the other. So I'll typically take 0.2 cc's in a 1 cc syringe with a 30 gauge cannula. In that 0.2 is 2 units. And I'll do 0.2 cc's with the 2 units here and 0.2 cc's with the 2 units on the other side. It's exactly what you think, what you would normally do. Good question, thank you. I don't get speech impediments, but I tell the patients that if they're smokers or they like to sip through straws, they're going to have a problem.
Yeah.
They're going to be a flat lip.
They're playing a musical instrument.
Right. What we're doing here, let's remember, when we treat the upper face, People say eradicate lines. Never was a big eradicator. I was a moderator. To eradicate lines between the glabella is great, but to eradicate all the lines of the lip means you have to have no movement. So it's moderation here, maybe obliteration up here. So I'm only going after moderation. What happens when you moderate a muscle movement rather than obliterate the muscle movement is that the brain resets. So if I was to do that on her, I would tell her in 4 days, you might find that when you're brushing your teeth, you'll have trouble keeping the toothpaste in, or you might have troubles with P's and F's, which can cause a little bit of a problem for the day, especially if you're a hockey player with pucks, right?
Yeah.
So
yeah.
you can say pass the puck. The other guy will get pretty upset if it doesn't come out as a P and more as an F. So what ends up happening is that it takes about a day and the brain resets. It understands that the muscle isn't moving as hard as it was moving before, and after a day or two, they talk normally. But if you overdose them over there and you go down too deep, you're going to get oral competence issues that are going to last a little bit longer. We're going to do your temple now because I want to see if I can cheat and try to get the tail of this eyebrow up a little bit. I would normally use toxin, but they won't get a chance to see it. You're crying. Did I hurt you? Or is that just that's, I think, a little bit of the ultrasound gel. Look how smooth that forehead is. I mean, you can see it shining off it.
Blends. It sits there, it just blends away.
So can I have the cleanser, please? Which is the one that's a chlorhexidine? That's it? Yeah, give me a squeeze. Beautiful. So we have the chlorhexidine here. I'll mark her just so the fact that you guys can see what the story is. This is the side I have to do, so I'm going to see if I can see it from here. I'll do it from here. Yeah, we'll see that. Okay. Let me have the marking pencil, please. That little black one will be fine. It's right here. Okay, guys, where am I going for a temple? 1 and 1. 1 centimeter up and 1 centimeter over, right? What? The other way. 1 centimeter up, 1 centimeter this way? Are you guys sure? Okay, we'll do it then. I'm looking for a target zone about over here. Do you agree? It's like making a square of 1 centimeter by 1 centimeter. I put my finger over it to see, does she have a pulse? The answer is no. I make sure she has one, period. The answer is yes.
But you can feel the notch. You can feel it. It's like a little golf divot when you feel it.
Okay, we're going to clean it, and then I need a dry sponge, which I have waiting over here. And here we go. Okay. I really can't see very well, but she doesn't want to hear that. There might be a vein in the way. There might not.
You can see better on the monitor than you can.
Yeah. So I'm in shadow over here. But here we go. We're going to put a little pinch over here. 3, 2, 1. And there you go. Okay. Now to show you where I am. You okay?
Yeah.
Perfect. I hope I don't hurt you here, but I'm driving the needles to show them that I can't go any deeper. I'm on bone. Okay, guys? I'm going to start the flow of product. I triangulate my finger always on the patient so that if they move, I move with them. You wouldn't be amazed at how many patients I have a needle in their face, their phone rings, and they go to answer it. You keep your finger behind here to prevent the product from going up in this direction. I want to force it to go here, here, and down. And I start my injection slowly. The slower the injection, the better the injector. I say that I'm slow, but Kent is deadly slow and makes him a better injector than me. I'm injecting. Look at the plunger. I can't see because the monitor's on the wrong side, Kent, but is everything okay on the monitor? They can see?
Looks good. Looks good,
okay.
yeah.
And I'm injecting slowly. Remember,
so vertical, and you're a pusher. He's doing anterior grade.
I'm maintaining the pressure on the actual temporal bone. Do you feel any pain?
You're not moving the needle.
You're going to hear little crackles.
And you're not moving the needle. You're keeping the needle right there.
Keeping the needle there. I do not want to withdraw the needle at all. Okay, I'm at 0.4. I started at 0.55, so I've put in 0.15. I've now put in 0.25. I'm going to get ready with my sponge. I'm going to withdraw. Oh, we were lucky. We didn't hear anything. And I'm going to put pressure.
You could be almost a chimpanzee and do this one.
I'm pretty much there. Okay. Why am I putting pressure, guys? I didn't see any blood. Why should I bother putting pressure? No, I don't think I'm trying to spread it. It's spread by itself. It's come up, it's hit the surface and spread. But you can. It's a possible thing. What's that? Right. And what deeper vessel is there for my plastic surgical colleagues? The sentinel vein. The sentinel vein is a vein that hugs around the area over here that we look for when we're doing forehead or facelifts that tells us the location of the branch of the facial nerve there. It's deep. If I happen to pierce that vein, it's unlikely that there's blood that's going to come up to the surface, but she's going to continue to bleed underneath the skin, underneath in the deep area. And she'll end up with a bruise 2 days down the road. And she'll come back to my office with a little greenish-yellow discoloration over there and say, I'm having trouble covering this, I'm not happy. Remember, it's all about the experience. You bruise them, you lose them. So I keep pressure here even if I do not see any blood. Got it? Because I have to assume that I've pierced that vein every time. I'm behind it, but I might have pierced it. Okay? So I keep pressure, and because I'm using a 30-gauge needle, maybe I have to keep pressure here for a minute at the most. I normally would be on the other side doing the other temple, or I'd be going on doing something else. Remember, the patient has 2 hands. They can help you too if your nurse steps out of the room. Oh, thank you, sweetheart. You go. That's okay. We're already done anyways. I'm going to erase this. Can I have a little cleanser again, please? Now, do you remember that brow was lower than the other brow before? Where is it now? Remember it was a lower brow? Go take a look in the mirror. Give her a mirror and let her take a look. Where is it now?
Oh my gosh.
Okay?
What I do often too, Arthur,
Yes.
what I do often too is just as you inject is hold the tail of the brow up,
Right.
and then you're going to anchor it, especially if you're using straight up product. You can anchor it a little bit if you got, she doesn't have much of an issue there, but if you got a tail that's hanging down, you lift that brow up as you're injecting.
There you go. It's a nicer look. It's a nicer look because the tail of the brow. Now, this is what I wanted to tell you guys. There's ways that you can shape the brow. Kent is an absolute maven or an absolute guru at this, at shaping brows with filler. If you put filler in along the brow line itself in this direction with cannula or with small needles, you'll cause a vertical lift and create the angle that you want at the eyebrow. Okay? So you'll cause the peak. But very often I have patients that come into my office and they say to me, Dr. Swift, can you do this? They pull laterally. Now I told you I have an unusual sense of humor and I drive my patients crazy, so I look at them and I go, am I doing it okay? They said, no, on me. I say, sure. Those patients are the ones that you want to put in a little fill over here. Don't make them convex. You want to make them just flat or slightly concave. You kick up the tail of the brow over there, raise your eyebrow, it moves beautifully, everything's working perfectly fine. Close your eyes really tight. She still has her orbicularis function, so why is her brow up? Take a look at it. Do you think that that brow is up because of the volume that I put in there of 0.15 or 0.25 cc's? That's what people keep telling me. They said, wow, you must have volumized that area. Look at how much more awake the eye looks on that side compared to the other side. Do I think that I was able to volumize her enough to cause that much of a lift? I don't think so. There's something else going on here, guys, and I'm trying desperately to figure it out. And I believe that what's happened is that the temporalis now has some support inside it and underneath it. It doesn't have to, it's just volume over there, and for some reason there's crosstalk between that muscle and the frontalis. The only elevator of the eyebrow is the frontalis, and the frontalis stops at the temporal fusion line. It can't be lifting here. It's got to be working here. And because I put filler in as well over here, I'm not seeing the creases that I would have if I was trying to lift my frontalis. Got it? It's a great little trick. We're going to just take a look at her apex that Kent is drawing out to make sure that she's in the right area, because I want to show you how a little difference in anatomy can do that. We'd love to do some other stuff. We'll save it for some other person. Maybe if somebody else wants to get a nose injected here. Okay. Okay. So we can do the nose because she has a beautiful nose. I mean, we could lengthen it by putting in some stuff over here. And Kent said we should put some in here and maybe drive the tip up a little bit. But she's got such a beautiful nose. You know, it's really pushing the limit. But I want to just show you a cheek now because we'll do the cheeks on both sides. She has, as Kent has drawn here perfectly, she has from mid-tragus to commissure, the Hinderer line that goes from the canthus to the oral commissure, And then he drew a horizontal line that comes across. We draw the oval. This is her ideal cheek mound for who she is. And if you take a look at that oval and we turn her a little bit like this, look how beautiful that oval is. Nice smooth contour. That's OG at its best. You see, that's why she's so pretty. Natural S curve, right? The question is, where is the light reflex on her, which is the last injection that we do. And the light, if we take a look at where the apex of her oval is when we turn her, the apex of her oval to me looks like to be about over here. That looks like to be the most projecting portion of her cheek.
Betsy, turn this way. Let's see.
Is that correct?
Yeah, right there.
Okay, right there. Let's see where I think it should be. I'm making you cry again. Or it's the lights, I guess. I hope. No, it's my cleanser. Okay. Okay. If you don't have a caliper, you grab the lateral orbital rim, you feel for the outside of the rim and the inside of the rim. It's a rim. It has an inside and an outside, and you put a dot right in the middle between the two. That's the bisection. You drop a vertical line right down, like a plumb line. Then you go from the alar groove to the top of the tragus over here, and you draw a line that comes straight across. Just about over there.
Show them where it is in men.
Okay? In men, what we do is we take the line from the outside of the iris, and we come down over here. It's a more difficult thing what you do with the man with the iris. Okay? And we take it from the base of the nose coming across to the mid-tragus.
The bottom of the tragus.
Right, bottom of the tragus, right here. And so her point for a man would be on this line, if we were to measure it with my calipers, would be very close. So she has a little bit of a masculine apex. Okay? Her apex is masculine down there. Let me get this right because I have it too wide on you. Her apex is masculine, down here, but I think it should be up here, which is more feminine. So we're going to put in a little bit of the voluma that we have. How much do we have left on this thing? Okay, I haven't left in my syringe 0.2 cc's. Can 0.2 cc's of a 1/3 blend do it on her? Let's have a little cleanser, please. We're going to see. Thank you so much. Anytime that I inject, I've got to make sure I can see it. I can't see because the monitor is the wrong way here. Anytime I inject, my hand's out of the way? Yes. Anytime I inject, I'm going vertical. You're going to feel a little pinch. I'm down on bone. I'm not moving my needle. I'm putting in a little bit of product. Very slow injection. And then I'll release and lift the skin a little bit and allow the product to maintain the tent pole. Remember, I only had 0.2 cc's in here. Bingo. Slow injection, never in a rush. I told you this is an area that bruises because of the arborization of the transverse facial artery. This is now finished. I'll take a cleanser, please. Thank you so much. I'm going to go ahead and clean this up. All I've done is moved her light reflex north, right, Kent?
Yes.
You can see it right here. I'm going to clean her up. So we say that a male's apex is like a baseball fastball, right?
Well, no, it's like a baseball catcher calling for the ball down and in.
Down and in. That's where you want to throw the fastball. Hard is down and in. It's down and in from a female. Okay, can I have the arnica gel, please? See, there's just a little drop of blood. It's the first drop of blood we've got because that's the area of arborization. I'm going to take a small little amount. Atta girl. Beautiful. Thank you. I'll hold some pressure here. And we're using the gel just so our fingers can feel what's going on under the skin because patients, when they get home, the first thing they do is they touch their face. If they feel a bump, you're getting a call at 8 o'clock at night. I'd rather know about it beforehand and see if I can massage it out.
You're not trying to move the product. You're just landing carefully and detecting areas that need attention.
Can you pan back out again, please? Is that crazy or what? Come on, that's a 1/4 of a cc of product, or 0.2 cc of product, which was really only 0.15 of product. Okay?